Welcome to Crash Cart Questions, the rapid fire challenge built for the emergency department. We're going to put your clinical thinking to the test, so let's get right to it. Okay, let's dive right in. No time to waste. Our first case is coming at you now. All right, here's the scene. You've got a 25-year-old man who collapsed after being pulled from a house fire. So he's obtunded, right? But check out these vitals. They're tricky. That SpO2 is a perfect 100%, which looks great on the monitor, but the VBG, that tells the real story. A pH of 7.10, lactate of 12, we're talking a massive acidosis here. This is screaming that something is going terribly wrong at the cellular level. So, what's on your mind? What's the diagnosis? If you're thinking cyanide poisoning, you nailed it. And the mechanism is everything here. Cyanide basically shuts down the cell's ability to use oxygen. It's like the oxygen is getting delivered to the front door, but nobody can open it to bring it inside. That's why the SpO2 is a total lie. So what do we do? 100% O2, supportive care, and the absolute key, the antidote, IV hydroxycobalamin. Okay, let's switch gears. Next case. We're going from a fire victim to a high-speed MVC. All right, so you've got severe pain, a really tense, swollen calf, and this is a big one, pain on passive stretch. Those are huge, huge red flags. But, and this is the part that can trip you up, his distal pulses are intact. That can give you a false sense of security. So what are you most worried about right now? This is classic acute compartment syndrome. And yeah, we all learned the P's, right? But you gotta remember, pulselessness is a super late sign. If you wait for that, you've waited way too long. The definitive management isn't watching and waiting. It's getting that patient to the OR for an urgent surgical fasciotomy to release that pressure now. Okay, now for a pediatric case. And this one is all about the clock. Every single minute counts here. Man, this presentation is just textbook. Acute, severe pain, a high writing testis, and the big one, an absent cremastic reflex. Every single sign here is just screaming surgical emergency. So, what's at the top of your differential? And what is your immediate next move? It's got to be testicular torsion. And look, while you should keep those other things in the back of your mind, your actions have to be for the worst case scenario. That means you're on the phone for an immediate surgical consult. You're making the kid NPO, getting IV access, giving pain meds, and prepping for the OR. Remember the mantra, time is testicle. And this leads us to an absolutely critical point. Testicular torsion is a clinical diagnosis. If you have a high suspicion based on your exam, you go. Do not wait for an ultrasound. The time it takes to get that scan could be the difference between saving that testis and losing it. All right, 3 cases down, nice work. But we're about to pick up the pace. Welcome to the Rapid Fire Gauntlet. 5 multiple choice questions, quick answers only. You ready? Let's do this. Question 1. We're talking about rapid sequence intubation. Suxamethonium is a great drug, but it has a really dangerous interaction with one specific electrolyte. Which one of these is an absolute contraindication? And the answer is B. Yep, hyperkalemia from a crush injury. Those crush injuries can lead to rhabdo, releasing a ton of potassium into the blood. Give Sux and you'll spike that K even higher, which can easily lead to a fatal cardiac arrest. You don't want that. Okay, question 2. Picture this. A patient with chest pain suddenly develops a new systolic murmur. That's a huge clue that something has gone mechanically wrong inside the heart. What's the underlying condition? The answer is B, acute coronary syndrome. Why? Because that MI could cause something catastrophic, like a papillary muscle rupture or blowing a hole in the septum, a VSD. Either of those will give you that brand new, terrifying murmur. Question 3, a classic lumbar puncture question. What are the CSF findings you expect to see in bacterial meningitis? Think about what the bacteria are doing in there. They're eating, and the body is fighting back. What does that look like in the lab report? You got it. It's B. You get high protein from all that inflammation. You get low glucose because the bacteria are just gobbling it up. And you get a flood of neutrophils coming in to fight the war. That's your classic bacterial picture. Question 4. Salicylate or aspirin overdose. When can you manage these patients supportively, and when do you absolutely need to call nephrology for emergent dialysis? Which of these is not an indication for dialysis? The answer is E. If a patient just has some mild tinnitus and their pH is normal, their labs are stable, you can manage them supportively. All those other options, severe acidosis, renal failure, pulmonary edema, Those are all signs of major systemic collapse, and that patient needs to be dialyzed right away. All right, last question. This is a pattern recognition special. We're looking for a hip condition that classically shows up in overweight adolescents and can be linked to endocrine problems. What is it? And the final answer is C, slipped upper femoral epiphysis, or SUFE. This is a can't-miss diagnosis for any adolescent who comes in with hip, thigh, or even referred knee pain. You gotta keep it on your radar. And that's it. You made it through the gauntlet. Fantastic work. Let's wrap this up. So, in just a few minutes, you've run through 8 high-stakes, high-yield scenarios that are designed to make you think fast. Because in the ED, the next critical patient is always right around the corner. If you want to keep your skills razor sharp, make sure you subscribe for new challenges every single week. Stay ready, and we'll see you for the next one.